and welcome to the TEOXANE Academy Virtual Expert Series. Today we are delighted to have Dr. Nabila Azib, plastic surgeon based in Rabat, Morocco, as a speaker. Dr. Azib holds several degrees in laser, dermatology, and reconstructive surgery. She is a member of several aesthetic learned societies and chairman of multiple international congresses. Dr. Azib has been an international lecturer for many years, and she's a member of the E2E group of European aesthetic experts, directed by Dr. Patrick Trevidick. So we are also thrilled to have today Dr. Patrick Trevidick, based in Paris, France. Dr. Trevidick is a plastic, reconstructive, and aesthetic surgeon based in Paris, as I just mentioned. Dr. Trevidick is chairman of the Reconstructive and Plastic Surgery Department at the Hospital Sainte-Anne in Paris, and chief of the Head and Neck Surgery Department. Dr. Trevidick is a recognized plastic surgeon of the French Medical Council, but also a member of many international reconstructive and aesthetic societies. Dr. Trevidick has published multiple peer-reviewed scientific papers and is a renowned lecturer in the aesthetic field, both in France and abroad. And we are really thrilled to have today both Dr. Nabila Azib and Dr. Trevidick dissecting and injecting live. So thank you very much for attending, and I hand it over to Patrick and Nabila.
Hi, everyone. We are very pleased to be with you. I hope you have the connection with Nabila, with her patient in Rabat, and with our dissection in Paris. So here, I want to show you the anatomical danger on this cadaver. So as you can see here, we did the dissection, and you remember that face is like a layer. You have multiple layers, and we will lift first the skin, and we will zoom on the mid-face where Nabila will do the injection. But first, before we zoom a little bit, as you can see, you have the superficial fat. And if I remove the superficial fat and the superficial fat compartments, you will discover, and we will dezoom a little bit, you will discover here the facial artery. Here, if we can zoom on this place, you will see the main danger of the face here. On this case, we zoom a little bit, and we open, as you can see here, the platysma, just to show you where is the facial artery. And this is the real diameter of this facial artery. And my cannula is a 22 gauge. Then this artery is deep at the anterior border of the masseter, that is just here. So this artery is deep and is going behind, you can see the artery here, behind the zygomaticus major that you can see. This cadaver has an anatomical variation because the platysma here is going up until here. That is very rare. Normally the platysma stop here. So this artery here is running up behind the zygomaticus major that you can see here, and is becoming superficial in the nasolabial fold. If we can zoom on this part here, on the nasolabial fold here, and we're going up and give the angular artery on the lateral side of the nose. So here, you have the anatomical danger, and in the mid-cheek groove that you can see here, you will have the facial vein that you see here. So from this line here, under this line, the dangers are deep. Above this line, it's far away from the tear trough, but it's just below the orbit margin that you see here. So 2 to 3 millimeters below.
So, Patrick, in my patient, it's important to locate this infraorbital foramen located under this levator labii superioris muscle here. Why? Because I don't want to inject and to make a pressure with my HA around the foramen first. And also for my entry point, if I want to avoid this danger, for the entry point for the T-trough and the orbitomalar groove here, I will use only one single entry point located at the intersection between both areas, but as you can see, far from the infraorbital nerve here. So now I will clean my side here, the side I will be injecting. The reason why I will start by volumizing the midface first is that I want also the orbital ligament, retaining ligament, to be lifted up, and then I will need probably less Reader-CT2 to use in the T-trough. Can you hear me, Patrick?
Yes, very well.
Are you okay with this treatment plan?
Yes, I agree at 100%, and I will follow you on the cadaver with RHA4, because you will start with RHA4 and the deep injection. So I'm ready to show you that, and RHA4 will be, as you can see here, a red, product. So you will see it very well in the deep fat compartment and superficial one.
So Patrick, you can see that my patient doesn't need a lot of volume. I mean, I just want to contour her. It's a kind of beautification, and I want her just to look less tired. So I will not use a lot of product here. I'm planning to inject in a multi-layering technique 1.2 ml of RHA4 in the midface, deep and superficial, and almost 0.5 ml in the T-trough and the orbitomalar groove. So I will need 1 syringe and a half for this side. So I always prefer to numb the entry point of my cannula. So that will be my first entry point for the midface. And for the T-trough, at the intersection in between both areas, I will also make a small papilla with lidocaine with epinephrine. So that will be my entry point. And the white area indicates where I can enter my 25 gauge needle. And here I'm using, for the deep fat compartment, RHA4, which is a 1.2 ml. So I already removed the air from my cannula, and you can see the molecules here. So I first stretch my entry point, I cross the dermis, I pinch each time I want to go deep, and you will hear a click, which is the zygomatic pus ligament here. Then you cannot see my cannula because I'm deep. I'm reaching the medial souffle. The bevel of my cannula is up. Open your eyes. I always ask my patient to keep the eyes open, and I inject only small aliquot, changing 1 millimeter the position of my cannula. I don't want to inject a large bolus in one shot. So here you can already see the lifting effect I had with only 0.1 ml of RHA4. And here the medial souffle is already with a good projection. If the skin of my patient was thicker and with a lot of lack of volume, then I will be using ultra deep, TEOXANE ultra deep in this area. Patrick, as you can see now, I changed the direction of my cannula, and I'm on the lateral souffle here. And the limit between...
I'm doing like you. I'm following you on the cadaver, so I'm going in the lateral souffle like you.
So Patrick, as you see, the limit for me is always the vertical line of the face located here, passing through the lateral canthus. So for me, the limit of the lateral and medial souffle is this vertical line of the face. So you can see that my patient feels that I'm on the bone. It's a little bit uncomfortable. But as RHA4 has also lidocaine inside, okay, respire, ça va? We have lidocaine inside, so it will numb the area. So only the first bolus is a little bit comfortable. Okay. So now I already injected 0.2 ml here on the lateral souffle. This is my preferred.
If we zoom a little bit on the cadaver, you will see the two bumps, a little bit like this. You see one bump here, that is the medial souffle. Here, the vertical line of the face with my catheter. And here, you see my lateral souffle injection on the bone, like you, Nabila.
Thank you, Patrick. So from the same entry point, I try not to go out with my cannula many often, but I just change the direction, and now I'm targeting the deep medial cheek fat compartment, but here I will inject only 0.2 ml. So just a click, as always, deep. So I inject first 0.1. I'm now on the deep medial cheek fat compartment, Patrick.
Me too. And you see that this is my zygomaticus major here. And the bump is just above this zygomaticus major, as you can see here. I'm injecting also deep. So you see 1, 2, and 3 deep fat compartment.
So I have 0.1 more to inject in this deep medial cheek fat compartment, and it's done. So I don't know if you can massage and model your product in the cadaver, Patrick, but me, I have to do it in order to
I can do it in an easiest way because I'm just on the ball.
Yes, me too, Patrick. And as you know, when we are in a good compartment, as it is surrounded by membranes, the product cannot migrate or move from this bag of fat compartments.
And also RHA4 is a forgiven product, so it's easy to mold, but it keeps its high strength. So for us, it's a very nice product because it's combining, you know, a product that will not keep a bumps, and on another way, it gives a lifting effect, a huge lifting effect.
So look, Patrick, at the effect that we had already in the volume, but also in the T-trough.
Yeah.
We have the T-trough. Do you want me to remove the drawing on the other side?
Yes, perhaps that will be nice. There is a brilliant article by Glazer, and you can ask TEOXANE for this article because it's an article published 1 year or 2 years ago showing that there is a relationship between the volume deficit and the tear trough. So it means if you have a volume deficit and a tear trough, you will take a great advantage for your patient to treat first the mid-cheek and then to treat the tear trough, as Nabila is doing right now.
Okay, Patrick, so now you can see the difference from the other side.
Yes, very well.
Tear trough. Now I want to give her some, like a highlight and contouring in her mid-face, and then I will enter more superficially, and to be superficial, I will stretch her skin to me to make like a resistance. I can rotate my cannula here and be as superficial as you see here. Now you can see my cannula. I will inject retrograding lines. I can do that with Teoxane RHA4 because you will have no palpability. You can volumize large areas and you will have no tingle effect. Sometimes I'm more superficial like this in some depression here on the mid-cheek groove. Sometimes it looks like the scar. When I have this kind of mid-cheek groove with the loss of elasticity, I can make also a dissection with my cannula and inject superficially like this with RHA4 without any risk. So here in my young patient, what I want is only to have a nice shape, and I would go more on the infraorbital superficial compartment here.
As you see, Nabila, on the cadaver, I do the same maneuver than you. I pull on the skin to be superficial. And as you can see here, if I show you where is my cannula is really, you know, in the superficial layers. You don't see my cannula because the cannula is inside the superficial fat. So I'm doing like you with RHA4. You remember it's a forgiven product, but it's a product will give you in the superficial layers the best, you know, lifting effect and contouring.
And long-lasting effect also, Patrick, because I tell my patient that this effect on the mid-face will last up to 18 months.
Yeah. And the last point, the last positive point is that you have in your syringe 1.2 ml of products. So 20% more than the classical volumizer and the main competitors.
Okay, Patrick, I just have 0.1 more. I will just try to harmonize my volume. And that's it. I used 1.2 ml of RHA4 in both layers, the deep and the superficial one, with one single product.
Patrick and Nabila, we actually have a question. We have a question on ethnicity. How and where would you inject the mid-face for Asian patients?
for Asian patients, because the skull is much broader for Asian patients. If we can dezoom on my cadaver, the face is more broader. So you have in the Caucasian patient, you will put more on the lateral SUF, but in the Asian one, you will put more in the deep medial cheek fat, because you need more in the mid face, but the medial face than the lateral face. And that's the same almost with gender and with male and female. Don't inject too much in female patients, in male patients, in the lateral SUF, or you will feminize the face of a male patient. I hope I answer.
Yeah, that's perfect.
Yes, this is in Asia, Asian patient, they prefer, the female patient prefer to have this heart-shaped face with more internal projection. So then it means, as you said, Patrick, medial SUF more than the lateral one. Patrick?
Yeah, we can go on.
Are we going to infraorbital area?
Yes, yes. May you explain your technique?
Yes, Patrick, safety first, once again, anatomy, technique, and products. This is the TEOXANE approach, ATP approach. So I think first anatomy, then for my entry point, I would be far from the infraorbital nerve. And then for the technique, my preferred one is the cannula, the short one, the 25 gauge for 40 millimeter, from one single entry point. And here I will be injecting theoxial ray density 2. And I know that now, after injecting the mid-face, I will need less product than I need to, if I do only the T-trough alone. So here, Patrick, I have 1 ml of theoxial ray density 2. I have a short cannula, which is a 25 gauge, which for me is very precise. I don't want to inject with a 27 gauge, which is as sharp as a needle. I avoid all the superficial veins, of course. I go to my numbed area. I cross the orbital retaining ligament. I control with my non-dominant hand that I'm not injecting inside the orbit. My patient is sitting at 90 degrees with the eyes open or looking up. Okay, if she looks up, zoom in. If she looks up, you will see better the T-trough. So now I will never inject superficially. I will be always deep along the along the bone, and avoiding injecting intra-orbital inside the orbit. The bubble is up. I first inject a first bolus, which will numb the area. Remember, it's 15 milligram by milliliter of mix of free and cross-linked HA. I already have a small bump here that I can model. It has also lidocaine. So this is why I inject from lateral to medial. I want to slide in an area which is numbed.
So
and then I inject the second bolus.
So here you see on the cadaver, you don't see my cannula, because my cannula is just above the bone, embedded in the bone origin of my orbicularis oculi muscle that you can see here. So my orbicularis oculi muscle, the superficial fibers covered my cannula here. So my cannula is really in the tear trough area, and my product will be embedded in the bone origin of the orbicularis oculi muscle. So it's deep, it's sliding on the bone, it's non-painful, as you can see on the patient of Nabila. You see she mold a little bit. Be careful, don't do a strong massage in this area, because ray density 2 is a product with a high spreadable product, so don't do a strong massage, mold it. It's a mix of cross-link and non-cross-link HA, plus lidocaine inside, and a little bit more for skin quality. But this product is very soft with a low hygroscopic property, 15 milligrams per ml of HA.
So look, Patrick, only with 0.2 ml, we have no more shadowing on the T-trough.
I will inject a little spot just for you to see where is my product. If you can see the elevation, I will push a little bit and I will put the blue. I don't know if you see on the cadaver the blue, but this is very, very nice to see here. where is the product? Okay.
Patrick, now if I inject only the T-trough on my patient, she will see only the shadowing that she has here on the lip cheek junction. So I want to make a complete treatment of her infraorbital area. So from the same entry point, I just change the direction of my cannula, and I will cross again the ligament, go to the bone, and as she has a thin skin for me, I prefer to create a hydrodissection. It's a little bit sensitive.
You see where I am here? I'm just behind the orbicularis oculi muscle. You don't see my cannula. You see my cannula is moving here, and it's behind my orbicularis oculi muscle. And in this area, it is the top of the soup here. I will inject a little bolus, and you will see perhaps the blue across here, the muscular fibers. You see the blue here, the bump here. Good. Yes.
Patrick and Nabila, we actually have quite a few questions on the treatment of the midface, because here you are using RHA4 to treat the midface. We have a lot of questions on the use of ultra deep and RHA4 in using the multilayering technique, for example. So could you comment on when and where you use all these different products?
Oh, in the case of Nabila, the patient has thin layers, so Nabila chooses to put deep RHA4 and superficial RHA4. But you will see with the next patient of Nabila, the second one, you will see a multi-layering technique with deep, ultra deep, that is a very stiff volumizer, and superficial RHA4 for the mobile area. So ultra deep needs to be in a place in a non-mobile area that are the deep fat compartments. And RHA4 needs to be not only deep, but also superficial for the mobile area, because RHA4 has a long chain of HA and is mobile with weak bonds, and so give a good strength, but follow the movement. Nabila, do you want to say something else?
Yes, exactly, Patrick. In a male patient or with the thick skin and with the important loss of volume, I will use the highest G prime product that we have in the range, which is ultra-deep. And I will use it exactly the same way that I did here with RHA4, so in the deep fat compartment, but I will never inject it superficially. Now that we have RHA4 for volumizing the superficial layers, I will use the multi-layering technique with ultra-deep and RHA4 more superficially. Patrick, can you see this lip cheek junction and T-trough disappear?
Yeah. You really remove the depression where the shadow can go there. And it's very important because the periorbital area attracts the shadows with the depression. And with your treatment, you erase the depression, and so you decrease the shadows in this area. So your patient in the right, and you shorten the lower eyelid. Remember, this is the main point. Where you inject like this in the right position, at the top of the soup and at the top, exactly in the tear trough, you shorten the lower eyelid. And you see here, if I use a blade, if I open just on the blue I put here, you will see I will be on the bone, on the orbital rim. So
I'm done in this side.
Good.
And you have a beautiful dissection, Patrick.
Yes, it's a very nice dissection, and I want to thank Gisela, that you know very well, that worked on this cadaver yesterday. And it's for that we have this beautiful dissection, and you can see all the anatomical elements. And we perform, this dissection just to have all the layers around here. If we dezoom a little bit, perhaps we will go to the next patient that will be a little bit longer, Nabila, and you will do the other side, perhaps in the back. Thank you. So I will just, at the same time that you change the patient, I will refresh, I will do a reminder on the lower face. If we can go a little bit lower with the camera and zoom on it, Perhaps take the profile camera if we can. It will be better.
So, Patrick, while you're changing the camera angle, we actually have quite a few questions still on the mid-face. Could you comment on the treatment of the palpebral groove?
Yes, the palpebral malar groove, it's, you have a palpebral malar groove because your patient lose her superficial fat compartments. It means your infraorbital fat compartment. So normally, if you will be logical and follow Mother Nature, if you want to compensate, you will have to inject superficial, but it's not what you are doing because you are afraid under this very thin skin of the lower eyelid, you are very afraid to get a bump or to get a swelling because this is the area of the malar mons. So the idea is to inject deep, and because you will inject deep in this area, as you can see here, you will be behind your orbicularis oculi, you will be above the bone and in a space between the orbicularis oculi and the bone. And here, there is no bone origin of the orbicularis oculi. It means in this area where I put my finger here, if we can zoom a little bit on the profile, here you have the bone, deep fat, muscle, superficial fat, and skin. This is not the case in the tear trough. In the tear trough, you don't have any deep fat. You just get the muscle sticks to the bone. So this is a main difference between the tear trough and the palpebral malar groove. And so for me, the secret is first to put small volume, this is the first point, then to inject slowly, and after to get the right product that is Redon CT2, that is the best product for this area. And you see here, this is where I put my product, and you can see here the blue, that is the Redon CT2 in the tear trough, but you don't see very well because it's embedded in the fibers of the orbicularis oculi. And you see the treatment I did. Here it's the medial SOOF, lateral SOOF, deep medial cheek fat, and this is the zygomaticus major, the smiling muscle of the face. So, Nabila, could you do the patient assessment to explain what you will do to this patient?
Yes, of course, Patrick. My patient is 63 years old, so now it's about rejuvenation and not only beautification. So each time I have to perform full face rejuvenation, my first start is with the mid face and the tear trough, and then I can go to the other areas. So if I sit her, okay, I will sit her, and then you can see exactly the proportions and the sagging skin that she has here. So this is what
we see very well. She starts to sag the jaw with the mandibular ligament.
Yeah, so this is the jaw. In an old patient, we can see this depression, which is the cutaneous insertion of the mandibular ligament. And just right behind the jaw, we have the pre-mesenteric, multiple pre-mesenteric ligaments. So in a young patient, if I want to locate the mandibular ligament, I push the jaw anteriorly, and then you can see this depression. Okay, so this is the jaw compartment. I will never inject in this compartment, but this is my challenge today. I want to lift up this jaw up here. So this is why I will be injecting on her mid-face and cheekbones here. I want to lift up this jaw. I want, in this way, I will inject the tear trough with the Bolus technique here and anterograde and retrograde injection here. And then I will go to the upper face first, because she has also, as you can see, a hollow in the temple, and we can see the bone here. So these are my three landmarks: temporal crest here, supraorbital margin, and zygomatic arch. So by injecting in the temple, it will lift also here in this area. My third step then will be the lower face. And again, this is the mandibular ligament. This is the jaw. And if I want to lift it back, I will inject in a multi-layering technique at the mandibular angle here to give her a little bit of projection of this angular mandibular angle, which has now a resorption, a bony resorption. And I will be using here ultra deep, but I will be drawing my jawline contouring more superficially with RHA4 here. Because I want to lift this jaw and hide this shadowing of the pre-jaw sulcus, I will be using also RHA4 with this entry point only superficially with retrograding lines here and superficial injection here. So that would be my 3 vectors, first up, then back, and then anteriorly. If we see her on the profile view, okay, now you can see her on the profile view, and you can see that she has a lack of projection also in the chin. So I will give her a nice contouring in the chin if we still have time.
Thank
Okay,
you, Nabila. You have a huge program on this patient, and at the time you are doing the disinfection of this patient, I will show some elements on the lower face. So we will focus on this lower face here. We'll zoom a little bit, and I will show you some elements Nabila explained to you. So if we can zoom a little bit on this area here. Okay, so we can go a little bit down. You see here a specific muscle here with a triangular shape. This muscle is the depressor anguli oris. And at the back of this muscle here, you get the mandibular ligament. So this is the mandibular ligament here. And if you are looking to the other place where you have another ligament, it's here, where you see the artery, fascial artery, and back you see the fascial vein. So here, what we call the buccomandibular ligaments here. So we have one ligament here, one ligament here, so 2 fixed points. And between these 2 fixed points, you have here the jaw that drooping down with the superficial fat. So as you can see in this deep, in this area of the mandible here, the only danger will be the fascial artery, and lower here, under the platysma, you get the submandibular branch. And if you are looking to the chin here, you can see a little branch going up, and this is the ascending branching of the chin. Nabila, if you want now to start.
Yes, about this ascending, they are inside the mentalis muscle. So when you will see me injecting in the chin, it will be a multi-layering technique, avoiding these ascending mental arteries. I will be deep with 3 boluses here and in the deep fat compartment, and in the superficial compartment, I will be very superficial with RHA4. And this is what I want to focus on, is that now the rheological properties of the RHA range allows us to be safer, I would say. We are never safe at 100%, but injecting very superficially in some areas where it's needed, we are safer. So again, mid-phase, the same entry point under the zygomatic arch here, tear trough. I mark all my entry points in the same, at the beginning. And you see that my blanching effect, I have this whitening will help me to know where to inject. So you see that I need a more powerful lifting product here for the medial souffle, lateral souffle, and deep medial cheek fat compartment. This is the reason I'm using now TEOXANE Ultra Deep here with a long needle, because I want to reach the deep fat compartment and also make some boluses along the zygomatic arch here. So I stretch the entry point, I cross the zygomaticus ligament, which is thinner than my previous patient. Sometimes you hear a click and sometimes not. I pinched, and I go straight to the medial souffle. Ça va? So I keep the contact with my patient. It's her first injection. It's the first time she's injected. So I explained that we have anesthesia inside the product, so it can be just a little bit uncomfortable at the beginning, but it's immediately not. So here I injected only 0.1 ml. My bevel is always up because I want all the SMAS, the deep fat, and the superficial fat to be lifted. 0.2. And I will add one more. I just changed 1 millimeter the position of my cannula. This is a habit I have now in all the areas I stop to inject large boluses in one shot. So I don't go out with my cannula. I will just change the direction and go outside the vertical line of the face, and then I go to the lateral souffle. So this is what we call the sexy point, but it's also in this lateral souffle, the area which will give me a nice lifting effect on my jaw.
So on the cadaver, you see a catheter here with the vertical line of the face. And you see here my cannula that is behind. I will hold this way. You see here, it's behind the orbicularis oculi muscle. And if we move a little bit this cannula, move a little bit, you see that it's just deep here in the lateral souffle.
So you cannot see my cannula, Patrick. You see I'm lifting my cannula. Yeah. You cannot see because I'm on the bone.
This is the advantage to remove the skin, the superficial fat. Then you can see the cannula. But it will be difficult without surgery.
I'm not sure she will accept.
Yes, I'm not sure too.
Then I pinch the skin and the SMAS again, and I will work from median to lateral, sliding on my 3 boluses. One here, and one here. I now already injected 0.5 ml of TEOXANE Ultra Deep. The tip of my cannula is located here. I inject 0.1. I slide a little bit more, and I will go till the hairline.
During this time, I will take a blade and I will show you where I am. So I will just open with my blade, and you will see that if I open straight on the bone and open the muscle and going in the deep fat, you will see here the blue HA that I put, in the deep layer. I don't know if you see it very well, but it's just here.
I don't need to inject her on the deep medial cheek fat compartment, because when I assess her, I see that it's not a compartment that lost the volume. So I concentrate my product in the medial souffle, lateral souffle, and all along the zygomatic arch.
I show with my cannula where you are with the tip of my cannula that is deep. So when people say, I don't know how I put my product deep, how I put my product superficial, as you see, Nabila give you, her tip and tricks. If you want to be deep, you push your cannula, but you lift with your 2 fingers of your non-dominant hands, and then your cannula will be deep. If you tight the skin, then you will be superficial. And the entrance point also is doing the job.
So look, Patrick, look, only with ultra deep, it's like restructuring the bone in this area, and you can see that the jaw.
Yeah, we see very well that you restructure, the mid face, and only with your ultra deep that has, the highest lifting capacity in the market, 25 milligrams per ml. It's really a stiff volumizer. You need only to inject on the bone. And my advice is not to inject this product when you have thin layers like the previous patient. In that case, if you want to get a very good lifting effect without any bumps visible under thin layers, you will have to use RHA4. So you see the algorithm of injection needs to follow the layers and the thickness of the layers where you will inject. You can't do the same for every patient. It's not possible, or you will have adverse events and you will have visible product. And so at the end, your patient will not be happy. So next step, Nabila, where are you going now with this patient?
I'm going more superficially, still in the mid-face. You see that she has a mid-cheek groove here that I will never inject from in the same direction, of course. I will cross the vein and the eventual facial artery that can be here in 20% of the cases. So my entry point is still lateral. Now I'm using RHA4, and I will be superficial. Then I stretch once again. Superficial, you can see my cannula. Retrograding lines. I'm planning to use only half of the syringe here. So RHA4 is also 1.2 ml. So in your treatment plan, you can give 0.6 for one side and let the other 0.6 ml on the other side. And look at how this Michi groove is now disappearing. Ok, je vous ai entendu petits à-coups. D'accord, mais c'est tout de suite avec la FDZ. So I'm just retracting, going back with my cannula. If I have any resistance, I rotate.
So in this area with your cannula, you feel when you are in the right plane because you slide in the fat. As you can see here in the cadaver, my cannula is entirely inside the superficial fat. If I lift a little bit this fat and I show you the deep layer of this fat, you see that my cannula is inside this fat. So doing a multi-layering technique, some people don't believe in this technique, but we have a lot of proof that it's working. It's working on cadaver. It's working when you do MRI. It's working always. So multi-layering technique, it's not to complicate your injection. It's to follow Mother Nature. You have 2 layers of fat in the midface, and these 2 layers of fat has an aging process. And so you have to compensate the 2 layers of fat. If you do only deep injection, you will put much more product for the same effect. So the idea is to put less product, but in the right layers and the right products too.
And also, Patrick, because these deep fat compartments are fixed into the bone, it's better to enhance their volume with a stiff volumizer to restore the volume, and to use a dynamic filler in this superficial fat compartment that are moving with the zygomaticus major, minor when we are smiling, and the result has to be beautiful on a static position, but also on a dynamic position. So, thoracic. Okay, we just turn the light. I just want to show you the effect on the cheekbones.
Very nice. You recreate, you know, this triangular shape that the patient lose when they are in the aging process. So we see very well the difference. It's much more smooth and it's elegant.
And we have less sagging in the jaw compared to the other side already. Do you want to go on the temple, on the
Yes, because we can see right now, Nabila, because you did a very good job in the midface, but we see on your patient that because she had a little depression before you start your injection in the midface, now she has a bigger depression in the temple. So you remember there is a relationship between the midface and the tear trough and the nasolabial fold, but for me there is also a relation between the midface here and the temple. If you inject the midface, don't forget to inject the temple.
Yeah.
Can you show how you do that, Nabila?
Really disappeared. Yeah, Patrick, I will mark my landmark here. Yeah, we will go to the temple.
J'entends plus.
Can you hear me? Wait, just 1 minute, Patrick. Patrick, can you hear me?
Yes, I hear you very well right now.
So this is my landmark, temporal crest, which is very
I will follow
visible.
you. So temporal crest, as you can see here. Orbital rim. And zygoma.
I don't know if your cadaver have visible veins, but my patient has.
Yes. You can see on my cadavers here, if I lift, you know, the fat that you get in the superficial layers, you can see here, if we zoom a little bit on it, you will see the little vessel in the superficial fat. And mainly, if we look at all these areas, so you need to go down a little bit with the camera. Descendez, voilà. Okay, you see here the main danger. This is your superficial temporal artery that will connect with the supraorbitalis artery and has connection, and also has connection, you know, backwards. And so this artery is the main danger. So if you inject in this area, and I will show you, because Nabila, we did a very beautiful dissection here. You see here the branch of the fascial nerve here. You see this branch here. I don't know if you see it very well on my camera, but here, this is my nerve, you know, going to the frontalis and this nerve is a fascial nerve. So all the main dangers are superficial. It's up to you, Nabila.
Yes, thank you, Patrick. I will work now on the temple, and then we will be back to the
Yep.
T-trough, if you don't mind. So in my patient, of course, I can palpate this big superficial temporal artery here, and in many cases, it follows one of the veins. So we have the vein and the artery following. So if I want to avoid it, for me, it's the best layer and the safest one is to inject in the supraperitoneal layer, inject large bolus. So here I'm using RHA4, 1.2 ml, and I'm using the long 25 milligram by milliliter. Sorry, the needle is long with the length of 25 millimeter. It's a 25 gauge. So I need a long one to reach the bone and to see the lifting effect. So I remove the air from my needle, and I will avoid the visible vein that I see here, and I will go straight to the bone at the maximum of depression. My patient could breathe a little bit because
okay, great.
Injection, which is a little bit uncomfortable. So now I'm back with my long needle, and I just change the direction and go a little bit lower than the temporal crest, injecting 0.1, changing again the direction. So you see, this is why I want to use a long needle. Look at the difference of depths in some areas of the temple. If I was with a 13 millimeter of length, the plastic part of my needle will push on the skin, and you cannot see the lifting effect and the result. So I always check that I'm injecting on the bone, because I don't want to inject inside the temporalis muscle, where we have the deep temporal arteries, interior and posterior one, which has a connection with the internal carotid system through the lacrimal artery. So for me, it's enough. I injected 1.1 ml of RHA4. I model the product, which worked like an implant. And I will show you the result from a frontal view. Can you hear me, Huda? Fabienne?
Yes, very well, Nabila. We hear you and we see you very well.
So here again, I need a dynamic filler in this area because I have a high dynamism from the temporalis muscle here with the mastication. So we don't see any hollow anymore. Here we have the temporal hollow, and here it's already disappeared. And it's also work on the lifting effect in the two other third of the face. Okay. Now we can go back to the T-trough with the redensity 2. Ça va? Mieux? Là, ça va être plus moins loin. So I have already my entry point. Zoom, I use a 25 gauge needle. Here again with my redensity 2. With the short cannula, to be more precise, 25 gauge, 40 millimeter. But now I know that because she has big palpebral bags and a deep hollow on the T-trough and cheek junction, I know that I will use all the syringe, not only half syringe as we did in the other patient. So I keep my syringe as a pen to control the direction and the depth, and since I'm on the bone, I can turn the bevel up and inject my first bolus. So it turns quickly, immediately, the shadow into light, and then I can slide on my first bolus. The tip of my cannula is now here. I inject another second bolus. Third bolus here. And sometimes in the inner part of the T-trough, I sometimes go a little bit more superficially and let a little drop, small aliquot at the angle, but very with a lot of precaution, just a drop.
Okay, thank you, Nabila. We have a question on the entry point. How to identify the safest entry point and where would that be?
For me, the safest one is the one located far from the infraorbital nerve here. So it is outside and upper. And it's also an entry point that will help me in my procedure. I want 1.4 in 2 directions. So you can place your cannula in the T trough. And this is the litchic junction. As you can see, my entry point is at the intersection between both. So the T trough has disappeared. Now we go to the litchic junction. Again, crossing the ligament, touching the bone.
Et puis retravailler après, hein, parce que là, c'est...
Patrick is back.
Yes, he's coming back, but we still have some issues. They are fixing it, so they should come back in a few minutes.
Yeah. So look, Huda, I've injected 0.5 in the T trough. And now I'm completing my injection in the litchic junction all along the bone. So it's up to you. You can also inject with a needle. It's not more dangerous to inject with the needle, but of course you can bruise if you have multiple entry points with the needle, you can bruise the superficial small vein that you have here. So with my lidocaine with epinephrine, I avoid also to have a big bruising. Now that I've injected the litchic junction with Redensity 2, I inject the last bolus in the transition at the limit between my 2 areas. And this injection bolus is just above my medial souffle, and it will complete the treatment. So I just model the product, roll my finger from down to up, not pushing in the product because I place it all along the bone. I don't want to have a print of my finger in the product. Can you see the difference between both eyes? Both. Okay, can you see Huda? Thank you. I can see some comments. Thank you. And I just use 0.9 ml of TEOXANE Redensity 2. Huda, can you hear me, Patrick?
No? Okay. Yes, do you hear me?
Yeah, Patrick, can you hear me now?
Yes, I hear you now.
And can you see the result of...
Yes, it's very, very good. And we are trying to solve this issue of the cadaver view, but it's a very nice outcome you get.
Thank you, Patrick. Should we go to the lower face? Or
yes, we go to the lower face. We'll try to solve this issue just to be in parallel with you if we can. But go on, Nabila, because we need to be on time.
Well, Patrick, I will start by the lower face, and when you will be back with the connection, we can do together the other lower face if you want.
Okay, good. Comment est-ce qu'on peut faire pour...
So now I want to lift back this jaw. I already have my entry point. How I locate my entry point? I put my finger lower than the mandibular angle here, and with my index here, I can palpate the posterior border of the mandibular angle. So I want to be at the most posterior part of the angle. So remember, as you said, Patrick,
il va le déconnecter, le connecter.
No danger deep, no danger superficial. And because it's sometimes very deep, I will use a 21 gauge needle. So it will not be painful, it's not. Why I use a 21 gauge needle plugged in my TEOXANE ultra deep? It's because I want to save time. I want to inject with a long needle and not a short one, but I want also to make already my pre-hole. So it's a long needle. I already removed some products from the needle. I also, with my non-dominant hand, block any risk of migration or injected in a small little vessel. Okay, so I block the blood flow. Here I already injected 0.2. You see me injecting small aliquot all along this mandibular angle, always changing a little bit the direction. So the only area where I will be superficial is between the pre-mesenteric ligaments here and the mandibular ligament, because here we have the deep facial artery. So in a bolus technique, I injected 0.4 ml of TEOXANE Ultra Deep here, and you can already see the difference in the projection at the angle between both sides. I don't want to make her squared. I don't want to get her better definition in her lower face and to pull back the jaw. My entry point is already done with my 21 gauge needle, so I can use my TEOXANE RHA4 for jawline contouring and harmonization in the jaw with the 22 gauge cannula. So look at the cannula. The red mark here shows that the bevel is up here. So I use the cap of my cannula and I really bend the cannula. So why I bend the cannula? It's because I want to avoid the hair, the rings, the earrings, and it will help me to be more superficial. So Patrick, I called it the straw drink technique. So I find that it's more elegant to drink with a straw drink that is bended. So I decided to bend the cannulas each time I need to be superficial. So the 21 gauge needle has already did for me the pre-hole. Then I can enter with the 22. So again, why I'm injecting with the 22? You see that along the pre-mesenteric ligaments and under the dermis, sometimes we can have some resistance like this. And with the 25 gauge cannula, in my experience, it's sometimes bent. I don't want to break a cannula under the skin. The limit of my injection here, you can see the cannula here. The tip of my cannula is just right here. I will not inject in the jaw. So my retrograde has to be a quick retrograde. I will model the product here. And once again, I can be as superficial as I want with my RHA. For in the pre-Trajan region here, I can also use RHA for like sticking here and pulling back all the cheek, the submalar area. I can harmonize. So remember, in the mandibular angle, I use 0.4 ml of TEOXANE Ultra Deep. And here, as RHA4 is a forgiven product, you will even not see the visibility of the product here. It will just stretch back the product. So the last thing I will do is that I will mark more and more, give more definition to the angle. So how I do that, I enter my cannula perpendicularly. I just change the direction here. I place my finger and I will push some RHA4 against my finger as superficial as you see here. I have a small depression here, so I will just continue. Voilà. The last drop will be for that area. Now, modeling the product. Can you see Patrick? Patrick, are you here?
Yes, we see it very well, Nabila. It's very nice.
I thought I lost.
And we will go right now to the anatomy to let you the time to finish on this side, and we will redo anatomy and redo this side when we will be all connected all together.
Okay. So I continue with the mandibular line and the pre-jaw. My entry point will be at the same direction. I need to continue my line here. So I will be using RHA4, but here with the short cannula, the 25 gauge cannula with a length of 40. RHA4 once again. In a very thicker skin, I could also use TEOXANE RHA3. So it's up to you. You can start by the line and finish upper in the pre-jaw. I'm very curious to continue first my line. So I will be pinching in between my two fingers and injecting it
Faut la
retrograde
laisser terminer. Hein.
of Theoxane RHA4 on superficial. That's superficial, Patrick. And sometimes I also make some decision just under the mandibular ligament, like here, I'm not injecting, just making some dissection, injecting a small bolus just under, at the lowest peak of the jaw, under the mandibular ligament. So here I'm trying to contour the mandibular line, injecting only between my two fingers that I put parallel here. And look at that definition, Patrick. It looks like we don't have any jaw anymore, right?
Very nice, Nabila. It's a very nice outcome. It was really a good patient, good indication, and it doesn't square our chin, so it's very, very nice.
Thank you, Patrick. Now I go up to the commissure, and I will harmonize very superficially like this, never injecting in the jaw. So sometimes I push the jaw to see the limit of the tip of my cannula, avoiding some visible veins here. But I always tell my patient that here in this area, it will bruise in 80% of the cases. We have a lot of small vessels, Patrick.
Yeah, it's superficial vessel, so it's not dangerous. You will see with the cadaver dissection that the dangers are more deep or deeper and behind the depressor anguli oris.
Yeah, so even with the cannula, it's sometimes bruised. So here I prefer the short cannula, once again, more precise. I will go up on the commissure here, outside the commissure, just to turn it up. And I injected only 0.8 ml of RHA4. So let's see if it's enough.
Very nice outcome. Very, very nice. Nice line.
I just want to add a touch up, and then we can go to the chin. For the chin, I will not inject a lot. It will just be, so 1 ml of RHA4 here. Pre-jaw, mandibular line. Another 1.2 ml of RHA4 superficially here, and only 0.4 ml of Theoxane Ultra Deep. Okay, ultra deep. So here I like to use the multi-layering technique also for the chin. The landmark in a female patient are, the lines passing by the alar nose. Here is the midline. So I will be injecting Theoxane Ultra Deep and RHA4 superficially here. The landmark in the male patient would be the length of the lips and not the length of the nose. Disinfection. We can inject also RHA4 deep in the chin area. So here, Theoxane Ultra Deep, again, with the needle that you have on the blister of Theoxane Ultra Deep, I start by 2 lateral bolus. So remember the anatomy, as Patrick told you, the ascending mental arteries. So I block the blood flow coming from these arteries, but I ensure myself that I'm always on the bone, with the bevel down to the bone. And here I inject a first 0.05, change the direction, another 0.05. In total here I injected 0.1, and here another 0.1. So we have already a nice projection. We will be symmetric, so my lateral point will be on the same level. I can check when I see my patient in profile view, what would be the best projection point. Of course, each time your needle touches the bone, it can be eroded. So for my last bolus, I will change the needle. So I inject always slowly for safety reason, and small aliquot. So anatomy is important, but the precaution with the techniques are important. The cannula, of course, are safer. So you can do that technique with the cannula also. So I changed the needle, so it will be less painful for my patient now. The last bolus is in the middle. So here you see that it's less painful for her. I injected 0.2 ml by bolus. Here 0.1. And for me, it's enough. So now we have the definition. We have the projection, but not yet the definition. I want some light to appear in her chin. So because it's a needle technique, it's bleeding a little bit. So now I change the product and I take RHA4. I could also take some remaining 0.2 ml of the RHA4 I used for the needle, because I will not use a lot. So I can enter in the midline and be in that superficial with RHA4. Short retrograding line, I injected 0.1, and here another 0.1. I'm superficial once again. And that's it. 0.2 ml for the retrograding line in the chin, in the superficial fat of the chin. Now I model it, so I keep my gauze and I model my 3 boluses. I stick them together and I smooth the retrograding line with RHA4. So this is her on the frontal view. Désolé. So can you sit, please? Asseyez-vous. Thank you. I will sit her, Patrick, just to show you the result. Are you here, Patrick?
Yes, I hear you very well. Can you show us on profile?
Yeah.
Or 3/4?
So this is the 3/4.
Yeah, very good. Very, very good.
And this is the profile.
Yeah.
This is her on the profile view.
Very good.
With a better balancing of her profile and hiding at the maximum as we can with fillers the jaw, which was sagging here, and that you can see still here on the other side.
Very nice.
So first step for me is always the mid face and the chin trough. Chin trough and mid face first, then the temple and forehead concavity, and then I finish by the lower face. So the cherry on the cake should be for her. I don't know, what do you think, Patrick, but it should be all these superficial lines that are visible here. So we have a dedicated product for that, which is the Result RHA1. I will be using it with the blanching technique to smooth all this barcode here.
Yeah. Perhaps, Nabila, we will see that just perhaps after the anatomy, and I will let you the 5 last minutes with the blanching technique. If you want to do the other side, start the other side, and we will connect with the anatomy with Paris.
Okay,
Is it possible to do it?
Then.
Okay.
Okay, super. Thank you, Patrick.
Okay. So here you see, I will do exactly what Nabila did. So here you see, I recreate the jaw here, as you can see on profile, and you have 2 fixed points to have a jaw. You have one fixed point here, that is a mandibular ligament, and another fixed point here, that is your buccomandibular ligament. So what Nabila did was to create a point in the mandibular angle, as you can see here, where is my mandibular angle. And she was going with ultra deep on the bone, touching the bone here, and injecting slowly a bolus. You can also inject a bolus in the mandibular ligaments here, deep on the bone, bevel down, injecting a small bolus. So if I look to this superficial fat compartment, you can understand why you get, this little bruising. Look at all these little vessels here. So the bruising is because of this vessel. And I will do like Nabila. I bent my cannula, as you see here, with my RHA4. I will introduce as Nabila superficially, sliding superficially here, as you can see, very superficial, and injecting, you know, my products, RHA4 with this line, and going on the other side up here, going to the ramus here, as you can see, and injecting, you know, superficially my RHA4. And then I will go superficial here, just like Nabila showed you, to the jaw. So injecting superficially in the fat, my RHA4, and going up after to the corner of the mouth, as you can see here, very superficial, and going up to the corner of the mouth. So if I lift my superficial fat, you will discover all this. You see my two ultra deep bolus, one in the masseter muscle here, and one in the mandibular ligaments here. And you don't see the red one, the RHA4, because the RHA4 is inside this fat here, these fat layers, these superficial fat layers. If I do the chin and you look on profile, we will zoom a little bit on this area here where I have my two fingers. Zoom a little bit. Then I will do my injection deep, as you can see here, going deep on the bone, like Nabila did, injecting a bolus here. You see it's lifting. And I will do also in this superficial fat here, above the mentalis that you see here, I will inject superficially my RHA4 in the superficial fat. So you see here, I'm in the superficial fat, and I will inject a bolus of RHA4 with my red product here. So you see a bolus here. My RHA4 is very superficial. If I cut my chin open here, you will see that I have a deep bolus in the deep fat, and I will have, you know, a superficial bolus. I will open my bolus here. You see the two colors with a deep injection in this area, a deep injection in blue in this fat here, and here you see it very well in the deep fat, and here you see the red one that is in the superficial fat. And between these two layers, you see the mentalis here, that is the muscle between the deep fat and superficial fat. So this is what Nabila did, you know, in the patient, and the danger in this area, as you can see, is here with your fascial artery here. Nabila, it's up to you for the blanching.
Okay. So, Patrick, I was trying to follow you with injection, but you are more quicker than me. So I will finish the other side off camera. So I like to use RHA1 with the mesotherapy needle, which is the 32 gauge, which is less painful for the patient and more precise. And as I know that you like to start by the forehead and the glabella, Patrick, so I will also go to this upper compressage. So this is my RHA1. It's a mix of free HA and cross-linked HA. It's only 1.9% of BDDE inside. And for me, I call it the eraser of superficial wrinkle. So look at the glabella line. This patient has never had any botulinum toxin. So with a hypercontraction, we have these static wrinkles that we need to erase. So the first step would be botulinum toxin first, and 2 weeks after this blanching technique. But as she doesn't want any botulinum toxin, we can go straight into review. So I want to be very superficial because remember here in between this line and this 2 centimeter of line, the supratrochlear artery can be everywhere, crossing the corrugator. So once again, being that superficial, pushing all the length of my needle under the epidermis, I place the bubble up. I enter 3 millimeters from the wrinkle. I stretch the skin. It helped me to push my needle. I need to see the zoom, s'il te plaît. I need to see the gray metallic color of my needle. And this whitening effect that you see is not a vascular compromise. It's the effect I want to have. If you don't have a whitening because you are under the epidermis and stretching the epidermis, then you will not be effective. So I use nano droplet of product very superficially, softening the product here with the hand or with the nails like this. And this RHA1 will last up to 1 year in these wrinkles, because here at this superficial layer of the skin, we don't have the natural hyaluronidase that will resorb it. RHA1 has the highest stretch of the range. It means that even when my patient will be frowning, after the movement, the product will be stretched with the movement and will be back to the initial shape and will not move from the wrinkle.
So,
and also we don't have any risk of Tyndall effect with the preserved network technology.
So I'm doing the same than you in the glabellar area with RHA1, and I will cut the cadaver just to show you where I am, to show you that I'm in the dermis. I cut it here, and I will show you with some hook. I don't know if you see that very well, but all the product is in the superficial dermis here. I don't know if you see that well, but you see the red colors. Can you hold this? You see here the corrugator muscle, the deep fat, the frontalis, superficial fat, and in the dermis, you see the red here is inside the dermis, so far away from the danger. And the product that is a mix of cross-link and non-cross-link RHA1, you have to just to be careful not to let any bumps at the end of the session. So you have to do a strong massage in this area. So this is a
so with your female leader, you can model it with your back of the nail like this.
Yeah. So you see here, where is my red RHA1 inside the dermis. Thank you.
So look, Patrick, the glabellar lines has disappeared already.
A lot of patients now ask for hyaluronic acid and RHA1 in this area because some patients, they don't want to get toxin when they have, headache when they had toxin, or they don't want to freeze all this area. So sometimes it's not only with combined technique and deep lines that you use RHA1, but it's also sometimes for the patient reason that you will use this treatment only HA for these lines. And it works well, and it lasts a long time. It's not easy to inject. You see Nabila, that is a brilliant expert in injection, but you have to start, and to do it. It takes time, but you see you can go fast, and you don't use a lot of products. So one syringe, it's largely enough to do a lot of lines, like a barcode, décolleté, necklines, glabellar lines, crowfeet lines. All these lines you can create with the blanching technique and RHA1.
So look at the other half, Patrick, a horizontal line disappears. Sometimes this line you see after botulinum toxin, we can still have a remaining sub-brow line here. So I can go also in this wrinkle. Of course, it's time consuming, but it's really interesting because a long time ago, we didn't have a product dedicated to the superficial wrinkles, and we can do the neck also with the same product. Here you see, Patrick, we will go down on the nasolabial fold.
Yeah.
You see that it's not interesting in her case to inject. My camera will follow, please. Okay. So it's not interesting to give her some volumes in the nasolabial fold with this sagging here. So it's just interesting to erase this wrinkle very superficially. You see that for the forehead, I use only 0.1 ml. It means that with 1 ml of RHA1, you can erase all the superficial line of the face. So I enter far from the wrinkle, and usually I'm asked why you don't inject on the wrinkle itself. So the answer is that I don't want the wrinkle to bleed. I just want to place the bevel behind the wrinkle itself and to push the product. So I push the bevel behind the wrinkle, I enter, and I make this area bleeding, but not the wrinkle, because I want to see the effect on the wrinkle itself.
I did it the same on the cadaver, and I will open again just to show you where I am. I open the line. And as you can see here, my product is in red, is in the superficial layers, nothing in the fat here. So the red product is just in the dermis.
I call it the eraser of wrinkles.
Yeah. Do you have any question, Fabienne?
Yeah, Patrick, we actually have some questions about the use of RHA1 for skin quality. Why, Nabila, did you choose RHA1 in this case and not Redensity 1, for example?
Because now I'm feeling the superficial wrinkles. I don't. Of course, it will improve the skin quality and it will enhance the thickness of the skin. Okay, but when I want to improve the skin quality, I combine RHA1 with Redensity 1. Example for the neck, I will inject the superficial lines with RHA1, but in between, I will use a multi-puncture technique with Redensity 1. I will combine both products.
Redensity 1 is a non-crosslink product, and RHA1 it's a mix of crosslink and non-crosslink. So RHA1 it's more for the fine lines, like you see here, but also improve skin quality. And if you combine with Redensity 1 that is dedicated to the skin quality, the glow effect of the skin, you have with these both products, you know, a good tools to improve the quality of your skin and the quality of the lines.
And with Redensity 1, it will go with the protocol. Here with the RHA1, the filling of the wrinkles will last 1 year, but with Redensity 1, we need 3 sessions with 3 weeks in between to improve and boost the skin with the good nutrients and HA.
So we see very well that you create like a mastress, you know, under these lines, because when the patients smile, we see that on the area, on the side, on the right side of the patient, we don't see the wrinkles. And when she smiles, on the left side, the wrinkles look deeper. So that's really interesting for us. Yes, it's very well. Okay.
Okay, it can work also on the wrinkles on the lower lip. So don't be afraid about this whitening effect. It's normal.
This is what you want to get, the whitening of the papilla. You know, it's papules, so the skin become white. It's for that the technique. The name of the technique is blanching technique, because you have to create papules. Because only if you have a papules, you know that you are in the dermis. If you don't have any papules, if you have just a lifting of the skin, you are too deep. So the product will not have the same action. Remember, it's a question of layers.
Yeah, Patrick, what I like to do also is that this barcode, these wrinkles are always breaking in the line, in the vermilion border between the red lip and the white lip. So what I like to do also is to use RHA1 to contour the upper lip.
Good. So do it, Nabila.
So I will be very superficial with my needle, injecting the first line here, injecting in an area which is now numbed, and once again, no risk of having any tingle with RHA being that superficial. I can sometimes use,
as you can see here, I did it on the lips, and if I open it, you will discover that my product will be what we call the virtual canal. It means very superficial in an area where there is a weak point between the red and the white. As you can see here, you see the red product is inside the virtual canal. So this is it's very safe, this injection in the lips. The Cupid's bow injection, the area here is very safe. Don't put too much because it will make like a duck lip, but it's not what you want to get. But if you put tiny amount, you will have a nice outcome, not only on the contour, but also on the lines barcode.
Okay, so now you can see the difference between the both sides. And if I ask her to smile, you can see that the natural, the dynamism would be normal, beautiful. Souriez. Souriez vraiment, franchement. Voilà. And faites un bisou. Give us a kiss. So I want to show you the disappearance of the wrinkles. So I'll place her like this and she will give you a kiss again. Bisou. Look, Patrick, all the wrinkles have disappeared already compared to the other side. Voilà. C'est bon, super. Voilà.
Very nice, very nice. I don't know if we have still time. I don't think so. Perhaps, Fabienne, you want to say a few words? So we saw on this, during this webinar, and sorry for this technical issue we had in Paris, but sure we will improve, you know that. So on a fresh cadaver, you saw the anatomy, and in parallel, you have Nabila in Rabat that was doing this two patients injection. I want to thank TEOXANE, and perhaps Fabienne, you want to say a few words before Nabila.
Yeah, thank you, Patrick, and thank you so much, Nabila, for this hectic, let's say, session today. So we are really sorry about all of the technical issues, but be assured that we will send you a full replay video of this webinar so that you can rewatch it and see a bit better the injection technique from Nabila and the cadaver dissection from Patrick. Nabila, do you want to say goodbye to the attendants?
Yeah, I would like first to say thank you for having me with Patrick. It's always a big pleasure to be with him. It's like you brought me straight from Rabat to Paris at Ferramoulin, and we're working as we were doing before. It's a big honor to me to have shared this live webinar with Patrick. Thank you so much. I'm so grateful for everything. Thank you, TEOXANE team, for the perfect organization and invitation, and hope to see you very soon.
Thank you so much, Nabila.
Thank you very much. Thank you. See you soon with our web.